Welcome to Public Health on Call, a podcast from the Johns Hopkins Bloomberg School of Public Health, where we bring evidence, experience, and perspective to make sense of today's leading health challenges. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes.
Hey listeners, it's Lindsay Smith-Rogers. Today, we're looking at two new policies in child welfare. Alex Adams is the Assistant Secretary for Family Support in the U.S. Department of Health and Human Services. He has changed federal rules to permit additional federal support for the treatment of opioid use disorder in the child welfare system. He's also urging states to allow children in foster care to keep the Social Security survivor benefits from their deceased parents. He joins Dr. Josh Sharfstein to explain these efforts and their connection to his own training in public health. Let's listen.
Alex Adams, thank you so much for joining me today on Public Health on Call. How are you doing?
I'm doing well. Thanks for having me.
You have a pretty busy job. You're the administrator of the Administration for Children and Families in the Department of Health and Human Services. Could you introduce yourself a little bit to our audience and explain a little bit what that administration does?
Sure. So ACF is the second largest operating division by budget at HHS. We oversee about $80 billion in funding for programs that trickle through states. Even if you've not heard of ACF, you probably know some of our programs: Head Start, Child Care Development Fund, foster care and adoption subsidies, a lot of the block grants that go through state governments like the Community Services Block Grant, Social Services Block Grant. So we're a financier and overseer of a lot of critical programs that trickle through state governments as well as some nonprofits. Prior to this role, I served at the state level. I ran Idaho's Department of Health and Welfare and oversaw many of those programs from the state perspective. So when I was at the state level, we were the direct administrator of these programs, would enroll individuals in those programs and work with community partners on those. So very familiar with them from the state perspective and now transported to the federal perspective.
And if I'm not mistaken, you are a pharmacist, is that correct?
Initially, I started my career in pharmacy and then broadened that with a public health degree from Johns Hopkins and was able to parlay that into my first state job. I ran the Board of Pharmacy in Idaho and then kind of grew in state government from there. I was able to run 4 different state agencies: Board of Pharmacy, Charter School Commission, the State Budget Office, and then our Department of Health and Welfare, which was our state's HHS umbrella agency.
But not at the same time. Okay. All right. Just checking. Okay. So you got this job, and there were a couple headlines that I saw that I wanted to ask about. One is that the Administration for Children and Families has changed its rules about whether grants can cover addiction treatment for parents who are involved in the foster care system. Could you explain a little bit what that policy is about?
Yeah. So this is a policy that relates to the child welfare system. So ACF spends about $12 billion annually to support state foster care systems. And in 2018, Congress changed the law and passed Family First Prevention Act. And it was a landmark change where rather than just subsidizing foster care, they made funding available to states who were trying to prevent entry into foster care for families whose children would otherwise be at risk. And if you just look at the statistics, the two most common reasons why children enter the foster care system is parents had a substance use disorder or the parents had a mental health or behavioral health issue. So Congress set it up where if something meets evidentiary standards to prevent entry into foster care, the states could claim a federal match on that. Right now, that match is 50%, but starting October 1st this year, the match would be equivalent to the state's Medicaid financial match rate, which is much higher than 50% in a lot of cases. So we, earlier this year, declared that the evidence was sufficient to meet the standards for medications for opioid use disorder as something that could prevent entry into foster care. Those include buprenorphine, naltrexone, and methadone. And why it's important is a state could now amend their 4E prevention plan and include those and claim a federal match on those. So that federal match is independent of the family's income. So as I said, starting in October, a state like Maryland, Josh, what's your FMAP in Maryland? What's the Medicaid match rate in Maryland? Do you know offhand?
50, 50%.
50. In my home state, Idaho, it's a 68%. So we'll take Idaho as an example. Starting this fall, if a family is at risk of their children entering foster care because of a parental substance use disorder, Idaho could claim a 68% match. So the feds would pick up 68%, the state would pick up 32%, regardless if that family qualified for Medicaid or not.
And that is for the medication, but also for the medical treatment that accompanies that?
Yes, it's part of a comprehensive plan. The child welfare system is generally the payer of last resort. So certainly a lot of families already qualify through Medicaid or maybe some other private coverage, but this was designed to allow coverage, allow federal match in instances in which a family either did not have private coverage or did not otherwise qualify for Medicaid.
It seems pretty straightforward because the evidence is very strong in support of treatment with those medications. But there's something more symbolic and important about this action, in my view, I think. And I wanted to ask you about that. For many years, parents have actually been punished in the foster care system for getting treatment for opioid use disorder, often because of the stigma associated with medications like methadone. And there have been cases where judges have said you can have your children back, but only if you stop taking the medicine that is actually treating your addiction and helping you stay healthy. Did you think about that history as you were changing this policy?
Certainly. Now, thresholds for abuse or neglect vary at the state level. Each state is going to have their definition. But in line with Family First Prevention Act, what we were trying to signal is that we want to address the root causes for the most common reasons for entry into foster care. Prevention is something that can be extremely beneficial. President Trump has said the best foster care system is one that's not needed. If we can prevent entries into foster care, you can prevent a lot of trauma associated with removal, both for the child as well as the parents. So trying to treat early the root cause of substance use disorder and preserve that family, keep that family together by appropriately treating and providing appropriate oversight can reduce foster care entries. The big campaign I've been running at ACF is called A Home for Every Child. And we're trying to increase the ratio of foster homes to foster kids, which on the surface seems like it's just a recruitment campaign. We're trying to recruit more foster homes, but that's not necessarily the case. The other way to increase the ratio of homes relative to the number of kids is to shrink the number of kids coming into foster care in the first place by preserving families, wrapping around families, supporting families, and making medications for opioid use disorder is certainly part of that.
Right. And I do think it hopefully will have the secondary benefit of destigmatizing effective treatment, both within the foster care system and outside of it too. So let's turn to the second policy, which has to do with survivor benefits for kids. I didn't really initially even understand what this was about, but it has to do with the Social Security system. Is that right?
Yeah, this was an issue I encountered when I ran a state health and welfare agency. Essentially, if a parent dies, their dependent children are entitled to their Social Security survivors benefits if that parent had worked. And it's intended to help meet the needs of that child. And in the case of a foster youth, if a parent had died and the child then later enters foster care, the state is now the parent. And in about 39 states, the states were then saying, well, as the parent, we will take those resources from that child and use those survivors' benefits to offset state costs. The argument from the state is that, well, the child's in foster care, we're paying a foster family room and board for them. So, yeah, we're going to use the orphan's own money to offset those costs. However, there are other kids in foster care whose parents did not die that the state is legally covering those costs for otherwise. So now you're treating children differently. If a child has access to a parent survivor's benefit, that child is paying their own way, whereas children who don't have access to that, the state is paying the full cost. And that seemed morally difficult to justify, especially when too many youth today age out of foster care with very limited resources. Many of them experience homelessness by age 26. Very few of them go on to higher education. And the resources left behind by the parents might be the only resources that they have. And it could be the difference between success or not in life for those children.
How much are we talking about for an individual child?
So monthly benefit, national average is about $1,100. So I mean, 3 years in foster care, you could be talking $30,000 to $40,000 that these children could have access to when they leave foster care. That's a significant down payment on a college education. That's
Right.
months to years of rent, depending on the market. So it's, state like Idaho, my budget running HHS was $5.5 billion. The amount that my state was taking from survivors' benefits across all of our children was $500,000. So in the grand scheme of my budget, it was relatively insignificant. But to those children, that was a significant and life-changing amount of money. So we ended it in Idaho. And then when I got sworn into office, I sent letters to the remaining 39 states that were still engaging in the practice and asked them to consider changing theirs as well, outlining moral justification for doing so. This legislative session, about 10 states changed that law, some through legislative action, some through executive action, and it was bipartisan. Blue states like New Jersey and Kentucky changed it. Red states like Nebraska, Louisiana, Mississippi, and Utah changed it. Washington made progress. They ended it for a certain age group, those who are 18 to 21. But there's ways to phase it down if needed, and Washington is kind of representative of that. So we've got about 29 states to go, and we're going to continue to chip away and try to encourage other states to do so.
Such an interesting issue. Do you have a sense of how many kids overall could benefit if you're fully successful, and how much money might be at stake for them?
It's been very hard to tease out specifically. We've been focused on the survivors' benefits aspect. Others have looked at SSI and some other programs, which are a little bit harder to disentangle from federal policy. So there is not a great estimate. The best I've seen was one third party estimated about $30 million nationally. And for context, the feds are kicking in about $12 billion child welfare as an example, just for scale. So if the $30 million estimate is accurate, it would reflect similar to what I said in Idaho, where it was a kind of insignificant number in the grander sense of my budget, but a significant number to those children.
I'm sure that's the case. Well, thank you for explaining that as well. I'm curious whether you think your public health training has helped in this world of child welfare for you.
Certainly. I mean, I'm a little distal from both my degrees, originally studied pharmacy and then public health. But, I think what public health really did and what Johns Hopkins did, I think my very first class at Johns Hopkins was a class on problem solving and how you define the problem, and then how you identify its key determinants, and how you put together a range of potential alternative options. I think it's a framework that can apply to many fields, including child welfare. And, when I came into this field, I felt like I used a lot of that. Well, how does a child end up in foster care to begin with? What are the key determinants? How do we go higher on prevention? So would like to think it influences how I approach the role for sure.
Well, thank you so much for walking us through those examples. I guess the first one did combine pharmacy and public health a little bit.
I'm so sure.
And thanks for taking time today to join me on Public Health on Call.
No worries. Thanks for having me.
Public Health on Call is a podcast from the Johns Hopkins Bloomberg School of Public Health, produced by Joshua Sharfstein, Lindsay Smith-Rogers, Stephanie Desmond, and Rachel Walsh. Audio production by Michael Bonfils, Matthew Martin, and Philip Porter, with support from J.B. Arbogast, Spencer Greer, and Chip Hickey. Distribution and social media by Rachel Walsh, with support from Nick Moran and Brianna Iacovelli. Follow us on Instagram and Blue Sky at Public Health Pod for more public health takes and special content. If you have questions or ideas for us, please send an email to publichealthquestion@jhu.edu. That's publichealthquestion@jhu.edu for future podcast episodes. Thank you for listening.